testing and sentinel lymph node risk prediction. I'll be discussing three commercial products of which I have no financial interest in. And these are my disclosures. They're not relevant to this presentation. So with respect to melanoma prognostics, we have a very good prognostic system based on conventional staging, based on over 40,000 patients and key pathologic variables: depth, ulceration, node status, presence of microsatellites. And based on this, we can predict pretty well who's going to recur and what their survival is going to be. But the staging isn't perfect. There are patients who fall through. We know that a small percent of early stage patients will ultimately develop metastases, and because these early stage melanomas are so common, they end up accounting for a large proportion of melanoma deaths. We know that adjuvant therapy has been approved in certain scenarios and has been shown to reduce recurrence risk, but how many patients actually benefit from that compared to those who suffer major adverse events? And then with respect to sentinel lymph node biopsy, as a staging procedure, about 80% of those procedures are negative. And looking at negative patients, some of those ultimately do suffer relapse, and some patients who have a positive node actually do quite well. So really there would be value in developing a molecular test to try to improve the staging accuracy and potentially inform decisions on performing sentinel node biopsy, also to inform frequency of imaging and benefit from adjuvant therapy. So prognostic GEP profiling basically is looking at gene expression in the primary tumor to try to predict the biologic behavior. Ultimately, to try to tease out if there's a subset of tumors that might be more aggressive and could require a benefit from a more aggressive treatment, and others that may not need as aggressive treatment. The way this is done is so after the biopsy is done, the tissue is in formalin-fixed, paraffin-embedded block. Sections are cut onto slides, and then from the tissue, RNA is isolated and then subjected to quantitative reverse transcription PCR, looking at expression of a finite panel of genes that have been validated, and based on expression of this limited panel, validated genes, the tumor is categorized either low risk or high risk. And the three tests we'll be talking about: DecisionDx Melanoma, or the 31 GEP test from Castle Biosciences; the Melogenics test, which is an 11-gene test developed and used in Europe; and then the Merlin test based on 8 genes from Skyline. So starting with the 31 GEP test, this looks at 28 different genes that have been associated with melanoma metastasis, and the 3 control genes. And this is just from the company website. Last year, 2025, over 39,000 tests done. These are on invasive melanomas. Based on invasive melanoma incidence, this translates to about a third of invasive melanomas in the US were tested last year. This is Medicare reimbursable, just over $7,000 is the cost. And last summer, this test received FDA breakthrough device designation. In its initial iteration, the test reported out either low risk or high risk, class 1 or class 2, and then subsequently subsets of those classes. So class 1A is the lowest risk. Those patients had the best or lowest risk of recurrence, and then class 2B had the highest risk of recurrence and poorest survival. And then more recently, several clinical pathologic factors, namely Breslow depth, ulceration, mitosis, and age, were integrated into the algorithm with the gene expression results to produce an integrated 31 gene risk of recurrence result. And from this one study, you can see they're looking at a subset of sentinel node negative patients. The test was able to identify some that had lower risk and actually did a little bit better, and then a group of patients who did worse than the general group. Then more recently, the test also reports out a integrated risk of sentinel node positivity with a low risk corresponding to a less than 5% risk. The other test that we'll focus on today is the Merlin test. This was developed in the Netherlands. It looks at 8 genes, and in addition to those expression of those 8 genes, incorporates 2 clinical pathologic factors, age and Breslow depth. This is designed to predict sentinel node positivity, and in the discovery cohort of over 700 patients who were undergoing sentinel lymph node biopsy, this was developed and validated. Subsequently, the test has also been looked at as a potential prognostic test, and in this study, over 500 patients with negative sentinel lymph node biopsy studied here, and then a subset of those looking at applying the test and that were high risk and had a very high predictive value there. And they were able to capture a significant number of those patients who did relapse. This test is also Medicare reimbursable, just over $3,000, approval in Europe. Commercially available here, but generally has not to date been widely used. We'll come back to that. There are a number of studies, now jumping back to the 31 GEP test, that have looked at how this test could influence decision making. And so this was one study in which they looked at over 500 patients whose tumors were tested, and then they investigated to what extent providing the clinician with the result influenced the management in terms of clinical follow-up, lab work, imaging, and in general, about half of patients, the management was affected, and in general, those that had lower risk result translated to lower intensity management, those with higher risk, higher intensity management. And then another study, the DECIDE study, in which looked at patients who were eligible for sentinel node biopsy. They had their tumors tested, and then shared those results and asked the providers if this influenced your recommendation for sentinel node biopsy. And about a third of the cases, it did influence a recommendation for sentinel lymph node biopsy. Over half of them influenced a recommendation to forego the sentinel node biopsy, but the recommendations weren't binding, and still some of those patients got sentinel node anyway. And so the point I would want to make here is that, yes, this has been studied in this context, but effect on decision making is not the same as clinical utility, which I would define as demonstration that there were actually better clinical outcomes in the patients. And there may be, but we just don't know that yet because we don't have any studies demonstrating improved outcomes based on the use of the test results. So the dilemma with GEP testing really is when you get a result that doesn't match the risk that would be predicted by the conventional AJCC staging. So for instance, a low risk T1A tumor, the guidelines say just do the excision, but let's say that had a high GEP test result, would you then escalate the intervention, recommend sentinel node biopsy, and maybe even imaging and adjuvant therapy, none of which would be recommended just based on the biopsy alone. And then here an example, a T1B lesion, guidelines say excise, consider sentinel node biopsy, but let's say the GEP test was low risk, would you de-escalate the intervention and maybe not recommend the nodal biopsy? And then a more advanced stage patient where adjuvant therapy after treatment and imaging would be recommended, but let's say it had a low risk result, would you then maybe not do some of those things that are recommended in the guidelines? And so the problem is we just don't have studies that would guide us to change management that have shown improved clinical outcomes based on the test results. So it really presents a dilemma when, particularly if you don't order the test and patients refer to you with a test result, then what do you do? Final test I'll talk about is the 11 GEP test, Melogenics. This is based on 8 genes developed in Germany, predominantly used in Europe. You get a low risk or high risk result. It hasn't been as studied as these other tests, but I bring it up really just because it's the only test that's currently being incorporated into a prospective clinical trial looking at outcomes. And so this involves 20 sites in Germany looking at over 300 stage 2 sentinel node negative patients. Those who, so they're all getting the test. Those that are high risk are then being randomized to nivolumab for a year versus placebo. And so this ideally will then give some information on whether more carefully selecting those who might be at even higher risk in this category, there might be a better risk benefit in that group compared to the negative side effects of the adjuvant therapy, might have a greater therapeutic index. And then similarly, you might also get information on the other arm of the study, which are those who test low risk of GEP. Those will just be observed. And so in 5 years, we'll have some idea of how safe it is to monitor those patients with a low risk result who otherwise might have been given adjuvant therapy. So recruitment's been completed, is complete, and the trial should be done in a couple of years. So we look forward to some results there. So now going back to the prognostic tests here, some general recommendations. Prognostic testing is not recommended for T1A lesions, although it appears that that's the majority of lesions that are being tested. There are a couple of studies that have been done looking at T1A lesions. Here's one study, 250 patients, and all of them had the lowest risk result. So we would expect at least a couple % of those patients would be expected to have recurrence long term. So potentially the test missed those. And then in a much larger study using this SEER DecisionDx database, 3,500 patients that looking at those that were had a class 1 low risk result, that was a result in 96%. So it's possible that the other 4%, the test identified as being higher risk, although we don't know yet if those are the patients that actually recur. So this is the problem, so that, in other words, the test may identify those at increased recurrence risk, but as I already mentioned, we don't really know how to manage those patients. But then there's also the risk of the false and negative reassurance that you would give to those patients who have a negative result, but we know a small % of those are going to recur. And then the false positive test, you might be causing unnecessary anxiety in patients or promoting interventions that might actually not be necessary. So what do the guidelines state? Because of low probability metastasis in stage 1A lesions, high proportion of false positive tests state that GEP testing should not guide clinical decision making in this subgroup. So now we're going to shift gears a little bit. So I've been talking about prognostic testing, looking at risk of recurrence, ultimately survival, to now using GEP testing for predicting sentinel node positivity. So I'll call this predictive testing. And so as was mentioned in the introduction, the role of sentinel node testing and the guidelines state that less than 5% risk, which I guess isn't, I'm not sure exactly where this came from, but maybe for any medical test, if the chance of it being positive is less than 5%, maybe it's not worth doing. 5 to 10% risk, consider and recommend greater than 10% risk. As I mentioned earlier, less than 20% of sentinel nodes are positive. How do we avoid the procedure in the other 80%? But there are a number of unknowns. We don't really know yet the impact of missing the sentinel node or of delaying adjuvant therapy if that biopsy wasn't done until they recur and then doing neoadjuvant. We haven't been able to compare those types of cohorts of patients, so we don't really know that information. But the idea here is, there is a clinical need to try to increase the precision, reduce the number of unnecessary biopsies. And so I'll just talk about the two tests, the 31 GEP and the Merlin test that I've already introduced you to. And again, the 31 GEP test gives you a low risk, high risk result, but then more recently will actually give you, with this integrated algorithm, will actually give you a % risk of positivity. The Merlin test, initially higher low risk, but I understand more recently they'll actually give you a % risk as well. And so a number of studies have been done on the 31 GEP test. And I'm not going to go through these, but just to point out, a number of them have been prospective. Interpretation of these is limited by several facts. A number of the studies have very few patients. Some have used overlapping cohorts. And I think also importantly, we don't know the actual sentinel node positivity rate or the rate in those with a low risk result in all the studies, because not all the patients got sentinel node biopsies. So that's kind of an unknown. But nevertheless, across all these studies, the negative predictive value, so how confident are you that the node is going to be negative if the test is negative, was quite high. With respect to the CP-GEP test or the Merlin test, not as many studies, but also fairly high negative predictive values. And then really focusing on the last column there, this is the large prospective study that will be discussed later, in which 1,700 patients were studied, large number of patients predicted to be low risk, and this was the result that they got. And so this was the Merlin 001 trial, and Dr. Angelis, we're fortunate to have a surgical oncologist with us today. She's going to talk about this trial and how it's really going to affect her practice. But the bottom line result is in the predicted low risk group, about 7%. So we were hoping it would be less than 5, but a little bit higher than that, had positive result, 93% negative predicted value. And these patients are going to continue to be followed, and so we'll have some idea of how well the test predicts outcomes. So there's the $7,000 test, there's the $3,200 test, there's also free tests, and these are the nomograms, or the sentinel node predictor tools. And so the first one from Memorial Sloan Kettering, there are various clinical pathologic variables you can see there. You just go to the website, you plug in the information, and it'll give you a predicted risk of sentinel node positivity. The other from Melanoma Institute of Australia, also involving age and depth, but then a little bit different in terms of the other factors. And you can plug that in and get an answer. How good are these? These have been studied in multiple publications. This may be one of the largest ones, looking at the National Cancer Database, over 60,000 patients. 15% were sentinel node positive, so comparable to maybe what we would see in most practices. They found that in this study that the MIA nomogram accurately predicted low risk, but may have overestimated high risk. And then several single institution studies looking at these. They both found that the models underestimated the sentinel node risk, particularly in the lower risk patients. And then there's one study with the I31-GEP test. Maybe it slightly outperformed the MSK model. And then after the initial study with the CP-GEP test was done, they went back and plugged all that information into both nomograms and reported that they felt that their test was slightly better. Subsequent study looks like maybe it wasn't quite as good as the MIA test. More recently, looking at just T1A patients who did undergo sentinel node because of high-risk features, very low overall sentinel node positivity rate, but it looked like the CP-GEP test was able to tease out some of those that were higher risk. So for low-risk sentinel node prediction, what do the guidelines state? Basically, they don't recommend use of any test in place of that consultation with the surgical oncologist. So as a dermatologist, you shouldn't be performing the test to decide, should we be referring this patient? Shouldn't replace that discussion. With respect to the nomograms, it says that they may have some utility, but only at a threshold less than 8%, not that 5% threshold. And then for the Merlin test, in patients where you would avoid the node biopsy if the risk really was less than 10%, not 5%, then it may be appropriate, it may have some value there. So let me just conclude with a couple of thoughts here. I think there is great potential for testing. We'd like to see these tests be useful. And indeed, there's room for improving our prognostics and prediction capacities. But we don't really yet know if they're any better than the free nomograms, at least for sentinel node prediction. And then even if the prognostic test is more accurate than conventional staging, is it going to be a difference enough that would be clinically meaningful and make a real difference in large group of patients? And we still don't really know who are the optimal patients to test. The test may be useful for informing decision on adjuvant therapy and imaging in scenarios that aren't currently advocated in guidelines. And despite the fact that these tests aren't recommended in the guidelines, routine use is actually increasing. But again, we don't really know what interventions are indicated based on the results. We may have improved outcomes, particularly in these scenarios where there's discrepancy between the test result and the staging. But again, we don't have data from prospective trials where patients are randomized based on a test result to show that they're better outcomes. So is one test better than another? We just don't know. Are these molecular tests worth the high cost? We just don't know, and we're not going to know until we can study these multiple tests head-to-head on the same group of tumors and same group of patients, and then compare them. And otherwise, we're not going to really know that. Can low-risk GEP patients be spared nodal biopsy adjuvant therapy? Does increased surveillance, more aggressive therapy, improve outcomes for high-risk patients? We're only going to know that if we can have randomized trials based on GEP test results and then look at outcomes. Feel free, that's it, thank you. Feel free to contact me if you have any questions. And I think I'd better just not take questions now, right?
Thank you so much. Thank you for that comprehensive evaluation of what's a very challenging topic. Our next speaker is Dr. Chris Bajakjian, whom I've had the pleasure of being on the NCCN panel forever and the AAD, and he's going to speak on Mohs surgery